All right, now to talk about some of the color Doppler factors to consider in the assessment of carotid stenosis. First of all, we'll talk about detection of luminal abnormalities, the presence or absence of helical flow and boundary layer separation, and finally some limitations of the carotid Doppler analysis. First of all, the intraluminal band are sometimes seen in the performance of carotid Doppler, and a band that crosses the lumen of the carotid artery can result from basically three sources, the most common being a free edge of atherosclerotic plaque. It can also indicate dissection or the presence of fibromuscular dysplasia and luminal webs. This is an example of a free edge of atherosclerotic plaque that is waving within the lumen, and we've done an M mode showing the motion of that free edge here. Dissections, carotid and arterial dissections, are usually seen as thin septations or bands, as shown here in this carotid artery, that shows different flow profiles on either side. In other words, if you put a spectral Doppler cursor on this side of the band or septation, you will get a different appearance to that waveform than you will see on the other side. In general, acute dissections can be very difficult to see because it is simply a very thin layer of intima that's raised in the lumen. In general, these become more visible as fibrin deposits on the dissection, and the dissection becomes chronic. Here is an example of another dissection, quite difficult to see on grayscale, but on color Doppler, the presence of that septation becomes more visible, and if you were to sample on either side, you would get different flow profiles. Another example, now this is a chronic plaque. You can see that this is more echogenic here. And here it is on longitudinal, then that, and you can see one of the flow profiles there. And if you sample it, you often get this, what some people call the stump thump phenomenon. Anyway, short, percussive, thumping waveform here, which is both muted and low velocity. Fibromuscular dysplasia one of the manifestations of fibromuscular dysplasia is a web that is seen protruding into the lumen, and this is an example of a young woman who had a stroke with no history of trauma or disease, and so if you see this in a young patient, you have to think about the presence of fibromuscular dysplasia. Helical flow is a phenomenon that's commonly seen and normally seen in many patients. This is flow that is helical in the sense that it has two components of motion. It is moving forward, and it is moving in a circular pattern within the vessel lumen. That's demonstrated here on these transverse images. In this case, flow is going in a clockwise direction. You can see that, but it is also moving, of course, cephalad towards the head. If you angle if you angle your transducer to demonstrate it. So it is going in two different directions. It's going in a circular motion, and it is going forward both in that helical pattern. If you sample the helical flow and longitudinal on either side of the vessel, you'll get you can pick up that component of circular flow. It will look like it's going away from you at one point, one portion of the vessel, and on the opposite side, it'll look like it's coming towards you, which in fact it is. It's not uncommon to see flow reversal, particularly around the bulb. This is a phenomenon that some people refer to as boundary layer separation, and it is a consequence of the fact that as a laminar flow enters a capacious area or a suddenly widened area, such as the capacious or the enlarged bulb, you will get flow reversal at the periphery of the vessel as that flow at the periphery is flowed to the point of flow reversal. Some people have so much as suggested that the absence of this boundary layer separation phenomenon at the carotid bulb itself indicates the presence of disease at this location. Here is an example of that. Here's the color Doppler. You can see this is true flow reversal and depicted here as flow below the baseline in this spectral Doppler tracing. I'll conclude the lecture with a series of pitfalls and pearls. First of all, there can be some variability of Doppler measurement based on technique, instrument variability, in other words, one machine to another, physiologic differences between patients, and finally, vessel and plaque morphology. There is quite a lot of controversy about the need for a uniform angle from one study to another. Suffice it to say that many people insist that the color Doppler angle should be the same for serial studies, and in general, those people advocate a 60-degree angle of incination. That the angle matters is indisputable. If you measure here and you change your angle, you can get a change from 140 to 195 centimeters per second, so that is quite a large change just by changing the angle of incination. So you want to keep that as uniform as you can. Remember that the angle of incination radically affects the reliability of the measurement. Measurements become much more variable when the Doppler angle exceeds 60 degrees. So all measurements of carotid velocity elevation or velocity should be obtained at 60 degrees angle of incination or less. There has been some controversy about whether the Doppler angle should be parallel to the wall or parallel to the jet, remembering that the plaque, of course, is frequently asymmetric and creates jets that are not parallel to the wall, but rather directed towards the wall. And the consensus is that the Doppler angle should always be measured parallel to the wall. Remember that gain can cause problems. Here's an example of two plaques. This one looks like it has intraplaque hemorrhage, but if you turn up the plaque even a little bit, you can see that there is quite a lot of echogenicity within the plaque, and that this is not the intraplaque hemorrhage that it appears. Sometimes the gain can be adjusted too high. This is an example of that. This is gain that is adjusted way too high, but when shown in color Doppler, what appears to be plaque is clearly not present. Finally, spectral Doppler gain can affect the measured velocity. If the gain is set too low, you can not detect some of the faster velocities within the vessels. And here, as I adjust the gain down lower, you can see that some of the faster velocities are screened out, and you get a difference of about 20 centimeters per second. There is some instrument variability. This is perhaps less than has been touted, but suffice it to say that if you do serial exams on patients, you should try to do it as much as possible on the same machine. If you use different machines, you can get some variability that's based simply on the variability between instruments. Then there are physiological differences between patients that can result in different measurements. Patients who are tachycardic or have a fast heart rate will tend to have a lower peak systolic velocity and a higher end diastolic velocity because of the lower filling of the cardiac chambers and the shortened time for the diastolic flow to decline. Patients with an exceptionally low heart rate or bradycardia will tend to have lower end diastolic velocities because the decline within the waveform is greater and the peak systolic velocities tend to be greater. Hypertension tends to result in higher peak systolic velocities. And again, if there are the presence of cardiomyopathies such that there is decreased cardiac output, in general that results in a decline in measured peak systolic velocities. This sort of decreased cardiac output is seen with cardiomyopathies and hypotension. Here's an example of this. This is a decreased peak systolic velocity measured in this case in the range of about 40 centimeters per second. In this patient with a cardiomyopathy, you can see that those effects are seen throughout the carotid system, both in the right system and the left, as well as the common carotid and the internal carotid. So the central abnormalities such as cardiac abnormalities or cardiomyopathies are seen globally through the carotid system. Cardiac abnormalities most often directly affect the absolute measure of peak systolic velocity. Using the peak systolic velocity ratio will usually compensate and give you some handle on degree stenosis. So if you have a patient with a low peak systolic velocity but with obvious plaque, I would suggest that you rely more specifically on the ICA, CCA peak systolic velocity ratio and correlate, of course, with the appearance on color and grayscale. Arrhythmias cause all sorts of problems for velocity, precision, and measurement. It is important that if you can identify a strip of several identical waveforms that you do your measurement there. Either that or choose the highest peak systolic velocity seen on the strip. Some people's arrhythmias are so irregular that you won't be able to find a pattern of 3 or more consistent waveforms, and in that case, your last resort is to use the highest measured peak systolic velocity that you obtain. Furthermore, because the Doppler, the vessel is changing direction very rapidly, it's difficult to identify a correct Doppler angle. In general, peak systolic velocity tends to be overmeasured in atorotrous vessels, and so I strongly suggest that you correlate with grayscale imaging and look for focal narrowing, because peak systolic because a true stenosis should cause poststenotic turbulence. Here is an example of a true stenosis. Here both, I should say that long segment stenosis can be another source of velocity variation. As you might imagine, a long segment stenosis in this plaque will be artifactually low because of the flow limiting quality of a long segment stenosis. Tandem lesions can frequently cause aberrant waveforms. And by tandem lesions, I mean lesions that are seen both proximal and distally, and measurement in the intervening segment will give you very bizarre waveforms as the flow pattern will swirl and eddy in that isolated segment. In general, the peak systolic velocity is less than expected in the segment marginated on either side by flow-limiting lesions, tandem lesions. In some cases, if you have a high-grade stenosis on one side, that will cause velocity elevation on the other side. In some studies, the use of ratios, that is the ICA-CCA ratio, does not compensate, and the effects from one side to the other can be highly variable. So in those cases, I recommend you use grayscale measurement and color Doppler to give you a better sense of the degree of stenosis on the contralateral side, the side away from the high-grade stenosis. So this is introduction to basic carotid sonography. I talked a little bit about how the study is performed, how to assess plaque in grayscale, spectral Doppler analysis, color Doppler analysis, and then some pearls and pitfalls. In a separate lecture, I will talk about waveform analysis. Thank you.